Hello ladies and gentlemen, this is Jeyasurya from Tagore Medical College with the continuation of the second part of this marvelous anatomical structure, the hand. This video contains the palmar arch of the hand, the nerve supply of the hand, the spaces of the hand, the dorsum of the hand, the dorsal digital expansion of the digits and the anatomical snuff box. Moving on to the palmar arch, the arteries of the hand are the terminal parts of the ulnar and radial arteries, and branches of these arteries unite and form the anastomotic channels called the superficial and deep palmar arches. Starting with the ulnar artery, this ulnar artery enters the palm by passing superficial to the flexor retinaculum and deep to the volar carpal ligament or the superficial slip of the transverse carpal ligament. It ends by dividing into the superficial palmar branch, which is the main continuation of the artery, and a deep palmar branch. Now, these branches take part in the formation of the superficial palmar arch and the deep palmar arch respectively. Now, the superficial palmar arch represents an important anastomosis between the ulnar and radial arteries, where the convexity of the arch is directed towards the fingers, as you could see in the diagram, whereas the convexity is directed towards the fingers, and its most distal point is situated at the level of the distal border of the fully extended thumb, as you could see in the picture. And this superficial palmar arch is formed as the direct continuation of the ulnar artery, whereas this is the ulnar artery, as you could see in the cadaveric image. This is the ulnar artery beyond the flexor retinaculum, that is by the superficial palmar branch. On the lateral side, the arch is completed by the superficial palmar branch of the radial artery. So this is the superficial palmar branch of the radial artery, somewhere joining here prior to going deep into the muscles of the medial compartment of the hand. Now, the superficial palmar arch, this is the superficial palmar arch, as you could see in the cadaveric image, lies deep to the palmaris brevis and the palmar aponeurosis, whereas these are the modifications of the deep fascia of the palmar aspect of the hand. It crosses the palm over the flexor digiti minimi, the flexor tendons of the fingers, and the lumbricals and the digital branches of the median nerve. Now, the branches given out by this ulnar artery are the superficial palmar branch of the ulnar artery, are the three common digital and one proper digital branches which supply the medial 3.5 of the fingers. So, as you could see in the cadaveric image, this is the superficial palmar arch. This gives out one proper digital branch and three common digital branch, where this is the first common digital branch, this is the second common digital branch, and this is the third common digital branch. Sorry, it lies somewhere here. Yeah, this is the third common digital branch, where these common digital branches split to give vascular supply to the adjacent fingers or the adjacent digits or the fingers. Yeah. Now, the lateral three common digital branches are joined by the corresponding palmar metacarpal arteries from the deep palmar arch, as you could see in the image somewhere here. These metacarpal palmar arteries come in anastomose with these common digital arteries. Now, the deep branch of the ulnar artery arises in front of the flexor retinaculum, immediately beyond the pisiform bone. Soon it passes between the flexor and abductor digiti minimi muscles to join and complete the deep palmar arch. Or it's somewhere here lies the deep branch of the ulnar artery. So it gets anastomosed with the deep palmar arch, whereas you could see quite deep here lies the deep palmar arch. And now, moving on to the radial artery. The radial artery runs obliquely backwards and deep downwards into the tendons of the anatomical snuff box, that is the abductor pollicis longus, the extensor pollicis brevis, and the extensor pollicis longus tendons, and the lateral ligament of the wrist joint, and the base of the anatomical snuff box that is formed by the bones of the scaphoid and the trapezium. Now further, they reach the proximal end of the first interosseous space and passes between the two heads of the first dorsal interosseous muscle and between the two heads of the adductor pollicis to form the deep palmar arch in the palm. Now this adductor pollicis muscle having two origins, that is lateral head, that is the oblique head and a transverse head, whereas these origins are from the shaft of the third metacarpal bone and the bases of the second and third metacarpal bone and the adjacent corresponding carpal bones, whereas they get inserted along the medial aspect of the proximal phalanx of the thumb fingers. Now this radial artery runs obliquely from the side of the radial pulse to reach the anatomical snuff box, and from there it passes forward to reach the first interosseous space and then to the palm, and whereas in the palm it gives out digital branches. It is also crossed by digital branches of the radial nerve, and this artery is superficial to the metacarpal bones and runs medially, whereas it at first lies deep to the oblique head of the adductor pollicis muscle and then passes between both the heads, that is the transverse and the oblique head of the adductor pollicis muscle to form the deep palmar arch. Hence it forms the deep palmar arch. Now this radial artery gives out branches along the dorsal aspect of the hand, along the lateral aspect of the thumb, that is the dorsal lateral aspect of the thumb, then gives out the first dorsal metacarpal artery, whereas this dorsal metacarpal artery, that is the first dorsal metacarpal artery, arises just before the radial artery passes into the interval between the two heads of the first dorsal interosseous muscle, and it at once divides into two branches for the adjacent sides of the thumb and the index finger, and along in the palm, deep to the oblique head of the adductor pollicis muscle, the radial artery gives off two branches, that is the princeps pollicis artery, which divides at the base of the proximal phalanx into two branches for the palmar surface of the thumb, and the radialis indicis artery, which descends between the first dorsal interosseous muscle and the transverse head of the adductor pollicis muscle to supply the lateral side of the index finger. So basically, in this picture you could see this is the princeps pollicis artery and this is the radialis indicis artery. Whereas moving on to something called as the deep palmar arch, this deep palmar arch provides a second channel connecting the radial and ulnar arteries in the palm. Whereas the first one being the superficial palmar arch already considered, and it is situated deep to the long flexor tendons. Now this deep palmar arch is formed mainly by the terminal part of the radial artery and is completely medially at the base of the fifth metacarpal bone by the deep palmar branch of this ulnar artery. So this arch lies on the proximal parts of the shaft of the metacarpals and on the interossei, whereas under the cover of the oblique head of this adductor pollicis muscle and the flexor tendons of the fingers and the lumbricals, and the deep branch of the ulnar nerve lies within the concavity of this deep palmar arch. Whereas in this picture, here somewhere lies the deep palmar arch, which is anastomosed by the or joined by the deep branch of the ulnar nerve, and the branches of the deep palmar arch are something like from its convexity, that is from its distal side, the arch gives off three palmar metacarpal arteries which run distally in the second, third and fourth spaces and supply the medial four metacarpals and terminate at the finger clefts by joining the common digital branches of the superficial palmar arch. Whereas here you could see somewhere around here they join with the palmar common digital branches of the superficial palmar arch, and dorsally the arch gives off three proximal perforating digital arteries which pass through the medial three interosseous spaces to anastomose with the dorsal metacarpal arteries. The digital perforating arteries connect the palmar digital branches of the superficial palmar arch with the dorsal metacarpal arteries, and the recurrent branch arises from the concavity of the arch and pass proximally to supply the carpal bones, whereas around somewhere here it turns around to supply the carpal bones and ends in the palmar carpal arch. Now, as you could see in this cadaveric image, this gives a clear picture of the superficial palmar arch, whereas this is the superficial palmar arch and this is the ulnar artery giving a branch, that is the deep branch, and it is supplying the medial 3.5 fingers, and it is joined by the superficial branch of the radial artery around here beneath the muscles of the thenar eminence. Now moving on to the nerve supply of the palmar surface. Basically, the ulnar nerve is the main nerve of the hand, whereas it supplies the medial 1.5 fingers by its superficial terminal branch, whereas the ulnar nerve enters the palm by passing superficial to the flexor retinaculum into the volar carpal ligament along with the ulnar vessels between the pisiform and the ulnar vessels where it lies, and it divides into the superficial and the deep terminal branches, whereas the superficial terminal branch gives out the medial supplies or innervates the medial 1.5 of the fingers and the palmaris brevis muscle, and the deep terminal branch accompanies the deep branch of the ulnar artery where it passes backwards between the abductor and the flexor digiti minimi, and then between the appendice digiti minimi and the fifth metacarpal bone lying on the hook of the hamate. Now finally it turns laterally within the concavity of the deep palmar arch and extends by supplying the adductor pollicis muscle. So as you could see in the cadaveric image, this is the ulnar nerve just giving out the superficial branch and a deep branch, whereas the superficial branch is supplying the medial 1.5 fingers, as you could see in the image, where it gives out a proper digital branch to the medial side of the fifth digit and or the little finger, and a common digital branch is seen here adjacent to the four sides of the fourth and fifth digits, whereas here lies somewhere the deep muscular branch, whereas it goes inside here, deep muscular branch. Now basically the branches of the superficial terminal branch and the deep terminal branch of this ulnar nerve goes like this, whereas the superficial terminal branch innervates the palmaris brevis muscle, and the two palmar digital nerves of the cutaneous innervation supply the medial 1.5 fingers of the with their nail buds, as you could see in the image. Here the ulnar nerve supply the medial 1.5 fingers along with the nail buds. This is the palmar aspect of the hand which is innervated by the ulnar nerve, and the medial branch supplies the medial side of the little finger, whereas the lateral branch is common to the palmar, is a common palmar digital nerve. It divides into two proper palmar digital nerves for the adjoining sides of the ring and the little fingers, as you could see in this picture. Now the common palmar digital nerve communicates with the median nerve, that we'll see in the dorsal aspect too. Now the deep terminal branch, as it originates from the deep branch that supplies the three muscles of the hypothenar eminence, as the nerve crosses the palm, it supplies the medial 2 lumbricals and 8 interosseous muscles, both the dorsal and the palmar interosseous muscles. The deep branch terminates by supplying the adductor pollicis and occasionally the deep head of the flexor pollicis brevis muscle. Now moving on to the median nerve. The median nerve enters the palm by passing deep to the flexor retinaculum, whereas it lies in the narrow space of the carpal tunnel in front of the ulnar bursa enclosing the flexor tendons. Immediately below the retinaculum, the nerve divides into the lateral and medial divisions. The lateral division gives off a muscular branch to the thenar muscles. This is the muscular branch towards the thenar muscles, and whereas this is the recurrent branch. The muscular branch curls upward around the distal border of the retinaculum and supplies the thenar muscles. Out of the 3 digital branches, 2 supply the thumb and 1 the lateral side of the index finger. The digital branch to the index finger also supplies the first lumbrical muscle. The medial division divides into 2 common digital branches for the second and third interdigital clefts, supplying the adjoining sides of the index, middle and ring fingers. The lateral common digital branch also supplies the second lumbricals. So basically, along the palmar aspect, the median nerve supplies the lateral 3.5 fingers, 3.5 digits with their nail buds and the 5 muscles, namely the abductor pollicis brevis, the flexor pollicis brevis, the first and second lumbricals, and the appenens pollicis muscle. Now, as you could see, for a clear perspective, this is where the ulnar nerve gives out branches. This is the proper branch of the superficial proper branch of the ulnar nerve, which is dividing into 2 parts and giving the innervating the medial 1.5 fingers along with the palmar along with the nail buds, and this compartment, that is the lateral 3.5 fingers along with the nail buds and the palmar aspect, is supplied by the median nerve. Now moving on to the clinical correlation, something called as the median nerve injury. It mainly happens due to the supracondylar fracture of the humerus, where the condition, the clinical condition exists something like the forearm is kept in the supine position due to the paralysis of the pronator muscles, and the hand is adducted due to the paralysis of the flexor carpi radialis, and the flexion at the wrist joint becomes weaker. And whereas the flexion at the interphalangeal joints of the index and the middle fingers are also lost, so that the index and the middle fingers, to a lesser extent, the fingers tend to remain straight while making a fist. Now this is called something like the pointing index finger occurs due to the paralysis of the long flexor digits. Now there is something called as the ape or the monkey thumb deformity presentation due to the paralysis of the thenar muscles or the muscles of the thenar eminence, and the area of the sensory loss corresponds to its distribution in the hand, something along the medial 3.5 digits along with the nail buds. Now moving on to something called as the wrist drop. This wrist drop is due to the injury of the radial nerve that is supplying the extensor compartment of the forearm and the major part of the dorsum of the hand. Whereas this injury of the radial nerve along the medial aspect of the humerus causes something called as the wrist drop due to the paralysis of the extensor compartment muscles. Now moving on to the nerve supply of the dorsal aspect of the hand, whereas the major component that is supplying the major component of the nerve that is supplying the dorsal aspect of the hand is the radial nerve, whereas this nerve in the hand is the continuation of the superficial terminal branch, where it reaches the dorsum of the hand after winding around the lateral aspect of the radius bone and divides into 4 dorsal digital branches which supply the skins of the digits as something like the lateral side of the thumb, the first branch, and the medial side of the thumb, the second branch, the lateral side of the index finger. This is the lateral side of the index finger, this is the lateral side of the thumb, and this is the medial side of the thumb. And the third branch supplies the lateral side of the index finger, and the fourth branch contiguous sides of the index and the middle fingers, whereas it splits and gives out to the index and the middle fingers. Whereas the radial nerve supplies until the lateral 3.5 of the dorsum of the hand until the middle phalanx, and the distal phalanx and phalanges of these 3.5 digits along the lateral aspect of the dorsum of the hand is also supplied by the median nerve along with the nail buds. Now, for the convenience, this is the ulnar nerve supplying the medial 1.5 of the fingers along with the half of the nail bud, 1.5 of the nail bud, and this is the radial nerve. This is the radial nerve supplying until the middle phalanx, and until this, that is until the distal phalanx is innervated by the median nerve along with the 3.5 of the nail buds along the lateral aspect. Now moving to the spaces of the hand, that is the palmar space, dorsal space, and the space of Parona. Starting with the palmar spaces consist of something like the mid-palmar space, the thenar space, and the pulp space of the digits. Starting with the mid-palmar space and the thenar space, as you could see in the picture, this is the palmar space, and the mid-palmar space lies somewhere around here, and the thenar space around the lateral aspect, and the pulp spaces at the distal part of the distal phalanges. Now, starting with the mid-palmar space and the thenar spaces, starting with the mid-palmar space, it is triangular in shape and located under the inner half of the hollow of the palm, and it extends proximally from the distal margin of the flexor retinaculum until the distal Palmar Crease. As you could see, this is the distal Palmar Crease of the hand or the palm. Now it communicates proximally with the space of the Parona, which lies in the forearm, and distally to the facial sheaths of the third and the fourth lumbricals, whereas it is bounded anteriorly by the flexor tendons of the third, fourth, and fifth digits, and second, third, and fourth lumbricals, and the palmar aponeurosis. And along the posterior aspect, it is bounded by the fascia covering the interosseae and the metacarpals, and along the lateral aspect, it is bounded by the intermediate palmar septum, and along the medial aspect by the medial palmar septum, and it is drained by the incision in either the third or the fourth web space. Basically, web space is nothing but the space between the two fingers when they are abducted. Now moving on to the thenar space, whereas it is also triangular in shape, as you could see in the image. It is situated under the outer half of the hollow of the palm, and it extends distally from the margin of the proximal transverse palmar crease and until the distal margin of the flexor retinaculum, whereas it communicates to the forearm space and the facial sheath of the first lumbrical distally, whereas it is bounded along the anterior aspect by the short muscles of the thumb, the flexor tendons of the index finger, the first lumbricals, and the palmar aponeurosis, and along the posterior aspect it is bounded by the transverse set of the adductor pollicis, and along the lateral aspect by the tendon of the flexor pollicis longus with the radial bursa and the lateral palmar septum, and along the medial aspect it is bounded by the intermediate palmar septum. It can be drained by the incision in the first web space posteriorly. Now moving on to the space of pulp or the pulp spaces of the fingers. The tip of the fingers and thumb contains subcutaneous fat arranged in tight compartments formed by fibrous septa, whereas these are the fibrous septa that are represented in green color, whereas the compartment between this fibrous septa is called as loculi, and this is the bone, that is the periosteum that you could see, and these are the digital arteries that are supplying the distal phalanx, and this is the flexor tendon of the finger, and this is the fibrous flexor sheath, which is the modification of the deep fascia of the digits. Now the infection of this space is known as something like the infection of Whitlow or the Fallon, whereas it rises by the tension along these spaces, which give rise to something like the throbbing pain, whereas the infections in the palmar space can be drained by the lateral incision, which opens all the compartments and avoids damage to the tactile tissue in front of the finger. If neglected, this Whitlow or the Fallon may lead to necrosis of the distal 4/5 of the terminal phalanx due to the occlusion of the vessels by the tension. So basically, these palmar spaces are affected due to the liquefactive necrotic secretions produced by the gram-positive bacteria, something like the community-acquired methicillin-resistant Streptococcus aureus and the Streptococcus family. Now moving on to this is the main clinical correlation for the pulp space, that is the infection of the pulp space due to that is called as the infection of the Whitlow or the Fallon, whereas there causes the avascular necrosis of the terminal phalanges. Now moving on to the space of Parona or the forearm space of Parona, it is the rectangular space situated deep to the lower part of the forearm, just above the wrist bones or the carpal bones. It lies in front of the pronator quadratus muscle, which helps for the pronation of the forearm, and deep to the flexor tendons, and superficially the space extends up to the oblique origin of the flexor digitorum superficialis muscle, and inferiorly it extends up to the flexor retinaculum and communicates with the mid-palmar space. The proximal part of this flexor synovial sheath protrudes into this forearm space or the forearm space of the Parona. The forearm space may be infected through infections in relation with the synovial sheaths, especially the ulnar bursa, whereas you could see in the image, this is the ulnar bursa and this is the radial bursa, whereas the space of Parona lies in between the ulnar and the radial bursa, somewhere here. So this is the place for space of Parona, which is lying between the ulnar and the radial bursa, whereas the ulnar bursa covering the flexor digitorum profundus and the superficialis muscle tendons, and the radial bursa covering the flexor pollicis longus tendons. Now moving on to something called as the prior to that, the pus points at the margin of the distal part of the forearm, where it may be drained by giving incision along the lateral margin of the forearm due to the infection of the radial bursa. Now moving on to the dorsal spaces of the hand. Basically, there are two dorsal spaces of the hand, that is the dorsal subcutaneous space and the dorsal subaponeurotic space, where the dorsal subcutaneous space lies immediately deep to the loose skin of the dorsum of the hand, and the dorsal aponeurotic space lies between the metacarpal bones and the extensor tendons, which are united to one another by a thin aponeurosis. Now moving on to the dorsum of the hand. The dorsum of the hand, as you could see in the cadaveric image, the dorsum of the hand immediately After the skin lies the superficial fascia, whereas the skin is loose on the dorsum of the hand, and it can be pinched off easily from the underlying structures, that is the superficial and the deep fascia. The superficial fascia contains dorsal venous plexus, cutaneous nerves, and the dorsal carpal arch, whereas the deep fascia on the dorsal aspect of the hand or the wrist is thickened to form the extensor retinaculum, which holds the extensor tendons in place. It is an oblique band which is directed downwards and medially about 2 cm broad vertically. So it is attached laterally along the anterior border of the radius. So this is the extensor retinaculum, as you could see in the cadaveric image, and medially along the styloid process of the ulna, somewhere here, and the triquetrum and pisiform bone. Now this extensor retinaculum sends down septa which are attached to the longitudinal ridges on the posterior surfaces of the lower end of the radius. So by this way, 6 osseofacial compartments or tunnels are formed on the dorsal aspect of the wrist, and the structures passing through each compartment or something like the first compartment. This is where the first compartment lies, somewhere around here, starting with the lateral aspect. This is the first compartment where it is occupied by the abductor pollicis longus muscle and the extensor pollicis brevis muscle, whereas this is the abductor pollicis muscle and this is the extensor pollicis brevis muscle. On the other hand, moving to the second compartment muscle consists of, whereas here also you could see this is the first compartment muscles, this is the abductor pollicis longus and this is the extensor pollicis brevis muscle. Here lies somewhere around the lateral aspect. Now moving on to the second compartment, that is the extensor carpi radialis longus muscle and the extensor carpi radialis brevis muscle occupies the second compartment, whereas the extensor carpi radialis longus and the extensor carpi radialis brevis muscle lies somewhere around here. And moving to the third compartment consists of a single muscle, that is the extensor pollicis longus muscle. This is the extensor pollicis longus muscle that you could see in the cadaveric image. And the fourth compartment consists of the extensor digitorum, which gives out branches, as you could see in this image and also in the cadaveric image, whereas this is the extensor digitorum this is the extensor digitorum muscle, and it gives out extensor indicis muscle, and also there lies the posterior interosseous nerve and the anterior interosseous artery beneath these extensor digitorum and the extensor indicis muscles. Now moving on to the fifth compartment, which is composed of the extensor digiti minimi muscle. This is the extensor digiti minimi muscle, as you could see in the cadaveric image, and the sixth compartment is composed of the extensor carpi ulnaris muscle. The extensor carpi ulnaris muscle lies somewhere around here. This is the sixth compartment muscle, the extensor carpi ulnaris muscle, deep to the extensor retinaculum. Now moving on to something called as the dorsal digital expansion. The dorsal digital expansion is a small triangular aponeurosis related to each tendon of the extensor digitorum, covering the dorsum of the proximal phalanx, and its base, which is proximal, covers the 𝗵𝒂𝒄 joint, and the main tendon of the extensor digitorum occupies the central part of the extension, and it is separated from the 𝗵𝒂𝒄 joint by a bursa. As you could see in the image, this is the extensor digitorum tendon, which passes all the way along the phalanges of each fingers, and along the posterolateral corners of the extensor expansion, or this is the posterolateral corners of this extensor expansion, these are joined by the interosseous muscles and the lumbrical muscles, whereas this is the lumbrical muscle and these are the interosseous muscle, as you could see in the image. And the corners that are attached to the deep transverse metacarpal ligament, and the point of attachment of this interosseous proximally and the lumbrical distally is often termed as something called as the wing tendons. This part is called as wing tendons. Near the proximal interphalangeal joint, the extensor tendon divides into a central slip and two collateral slip. This is the central slip, and somewhere around here are the two collateral slips, where the central slip is joined by some fibers from the margins of the expansion and crosses the proximal interphalangeal joint and is inserted on the dorsum of the base of the middle phalanx. As you could see here, you could see along the base of the dorsum of the middle phalanx, it gets attached. And the two collateral slips, these are the collateral slips, right? These are the collateral slips, are joined by the remaining thick margin of the extensor expansion. This is the remaining thick margin of the extensor expansion, and they join each other and are inserted on the dorsum of the base of the distal phalanx. Now at the metacarpophalangeal joint and interphalangeal joints, the extensor expansion forms the dorsal part of the fibrous capsule of the joint, and the extensor retinacular ligaments extend from the side of the proximal phalanx. As you could see in the image, this is the proximal phalanx, and form its fibrous flexure sheath to the margins of the extensor expansion to reach the base of the distal phalanx. So it originates here and extends distally to get inserted along the distal phalanx. Now moving on to the clinical correlations, something like the mallet finger or the baseball finger or the cricket's finger. It is also called as the 𝗏 deformity. This 𝗏 deformity is a common clinical sign for even rheumatoid arthritis, and this mallet finger, due to the insertion of the extensor tendon into the base of the terminal phalanx, might get torn due to the forceful blow on the tip of the finger that causes a sudden and strong flexion of the phalanx, and occasionally some small flakes of the bone may be avulsed, and consequently the distal phalanx assumes a flexed position with a swan neck deformity, and voluntary extension is impossible. This condition commonly occurs with the cricket and the baseball players. Now moving on to something like the Boutonniere deformity, where it is opposite to the mallet finger deformity, which is characterized by the flexion of the proximal interphalangeal joint. This is the proximal interphalangeal joint, whereas the mallet finger is at the distal interphalangeal joint. So along the proximal interphalangeal joint and hyperextension of the distal phalanx, and it occurs due to the flexed proximal interphalangeal joint pokes through the extensor expansion following the rupture of its central portion of the dorsal digital expansion due to the direct end of the trauma of the fingers. Now moving on to the anatomical snuff box. So the anatomical snuff box is something like a depression, the triangular depression along the dorsal aspect of the wrist, along the lateral side and lateral side of the wrist and dorsal aspect of the thumb when the thumb is completely extended. It is bounded anteriorly. As you could see, this is the anatomical snuff box. Hope the hand is properly extended, where this is the cephalic vein, you could see here. For a clear picturization, I would like to explain in the other picture, where anteromedially or along the lateral border or the radial border, lies the extensor pollicis brevis and the abductor pollicis longus muscle, and along the posteromedial aspect, or the medial or the along the ulnar border, lies the extensor pollicis longus tendon. This is the extensor pollicis longus tendon, this is the abductor pollicis longus tendon, and this is the extensor pollicis brevis tendon. Now these are the boundaries, whereas superiorly it is bounded by the styloid process of the radius bone. Somewhere around here lies the styloid process of the radius bone, and the floor of this anatomical snuff box is formed by the scaphoid and the trapezium bone. Now the contents of the anatomical snuff box are something like the radial artery. As you could see, this is the radial artery passing deep to the anatomical snuff box structures. There is the borders or the boundaries, and the superficial branch of the radial nerve and the cephalic vein, as you could see in the picture. Now moving on to the clinical correlation of this anatomical snuff box. There are a number of clinical correlations due to the importance of the content of this anatomical snuff box. Whereas the tenderness of the anatomical snuff box indicates a fracture of the scaphoid bone, and the pulsation of the radial artery can be felt in this anatomical snuff box. On the other hand, the cephalic vein at the site is used often for providing intravenous fluids through the cephalic vein. And on the other hand, the superficial branch of the radial nerve can be rolled over the tendon of the extensor pollicis longus muscle. And I hope that's a wrap. Thank you.